Dementia is becoming more common as the population ages, and practices with a relatively high population of older people are increasingly aware of patients presenting with memory difficulties. The development of a primary care memory assessment service allows such patients to be assessed and investigated promptly in familiar surroundings. In the majority of cases, they can also be diagnosed safely and managed appropriately without the need for specialist referral. This has the potential to improve the patient and carer's experience, leading to a more timely diagnosis and prompt access to the available support services. Here in South West Oxfordshire, we are pioneering this development in collaboration with the existing memory clinic. So, how is this going to work? Firstly, the Primary Care Memory Assessment Service is not a replacement of the existing specialist memory clinic services. Instead, it is an additional service and an alternative that may often prove more convenient to patients and their families. It will also enable primary care teams to develop the skills and resources to help manage the growing impact of patients with dementia. The Primary Care Memory Assessment Service will help practices achieve the National Dementia Direct Enhanced Service because the requirement to refer to a memory clinic will be met even though that memory clinic will be provided by the practice. A management protocol has been developed for the assessment and diagnosis of cognitive impairment and dementia so that all involved can feel confident that the Primary Care Memory Assessment Service matches the quality of the existing secondary care memory clinic services. This slide shows the content and order of the issues covered. So why should primary care get more involved? Well, it's estimated that at the moment only about 1/3 of people with dementia receive a formal diagnosis. Primary care is undoubtedly well placed to identify people with mild cognitive impairment and dementia, and such people often already have multiple other health problems, so managing these different conditions in the same patient allows for a more coordinated and appropriate level of care. The assessment and evaluation process to diagnose most people with dementia can be carried out more quickly in primary care, and GP practice is the natural link or hub to liaise the various care needs. Using an analogy with diabetes, much of diabetes management used to be carried out by secondary care services, but the growing prevalence of diabetes has led to the condition being now managed mainly in primary care. GPs and practice nurses have gained the required confidence and expertise in the process. The diabetes specialist services can still be accessed when a particular The perceived barriers to increased involvement in primary care were summarised in a recent review and included uncertainties about how to support patients and carers, especially when about half those in primary care felt that the secondary care services did not provide satisfactory support. GPs felt patients and carers could feel stigmatised by the diagnosis of dementia due to the loss of autonomy. There were concerns about making a diagnosis, although one study found that 2/3 of GPs did feel confident in their own ability to make a diagnosis. Some felt anxious about disclosing the diagnosis, although felt the approach of breaking bad news was appropriate. Others recognised that the act of investigating the patient for dementia in itself can enable patients or their families understand the possibilities about diagnosis and result in some relief. Noted that patients often presented late due to patients and families not recognising the symptoms. And finally, therapeutic nihilism describes the attitude that the diagnosis is pointless and because there are no available treatments, making the diagnosis could do more harm than good. It's an interesting reflection to note that these objections or barriers almost exactly mirror the prevailing attitudes to terminal cancer until the growth of palliative care in the 70s challenged and changed how those cancer are managed. We are all aware that the growing prevalence of dementia poses a challenge to health and social services as well as patients, their families and the communities they live in. These are just some of the issues that we face. Without innovation and considering alternative ways of doing things, we risk. This slide and the next show some of the statistics current and projected which explain why we need to plan now. The bottom line is that the number of those aged 80 and over is increasing rapidly and projected to rise from 1 in 25 to 1 in 10 of the population in a generation or so. Of course, dementia is not the only age-related condition that is increasing. This slide shows the rising numbers of those over 80 in Oxfordshire over the past 20 years. Not only is the total population increasing in southwest Oxfordshire as elsewhere in the UK, but the number of 80-year-olds is rising proportionately more. Over the next 2 decades, 2008 to 2028, the number of people aged 80 plus in Oxfordshire is expected to increase by nearly 24,000, an 84% increase, with the growth in rural districts well above that of Oxford City. As can be seen from the figures here, the prevalence of dementia is strongly linked to age. For interest, I have added the numbers in my own practice. Even though we have a nursing home in our area accounting for the higher numbers of the very elderly with dementia, it might seem we have yet to identify all our patients with dementia in the 70 to 80 age group. The average practice population of 5,000 outside cities can expect to have at least 50 patients with dementia. Governments around the world are having to consider how to meet the many and varied challenges of an ageing population, including those with dementia, and this led to the 2009 publication National Dementia Strategy, which had 3 key principles which are replicated in local Oxfordshire policy as well. The South West Oxfordshire Locality Initiative to develop the assessment and diagnostic process of dementia in primary care meets the strategic aim of facilitating assessment and improving memory clinic services. In the nursing home that my practice looks after, it is not uncommon to find patients with advanced dementia. This is not surprising, but what is surprising is that very often there is no record of a diagnosis anywhere on admission. A common scenario is that there is a gradual decline in patients' functioning and then a crisis which precipitates an acute hospital admission. Hospitalisation will generally exacerbate all the symptoms and signs of dementia, but while the hospital discharge letter will give information of a hip replacement, often no mention will be made of the diagnosis of dementia that must have been in evidence prior to the nursing home admission. We have already covered why so much dementia, especially early dementia, is undiagnosed. These were also summarised in the Facing Dementia survey, which gathered data from various groups across 6 European countries in 2004. It reported a culture of concealment, minimisation or ignoring early symptoms and signs, so that the large majority of people with dementia either do not receive a diagnosis at any stage or only late or in crisis, when it is often too late to prevent harm such as a breakdown of care and institutionalisation. The reluctance to make a diagnosis of dementia is not solely a hospital care or primary care problem. Even when patients are referred to specialist memory clinics, the same problems seem to apply. This slide shows the results of an audit of letters from memory clinics to GPs in Oxfordshire. It was commissioned by the clinical director of the memory clinic services. In total, only 1/3 of the clinic letters included the current diagnosis, and less than 1 in 5 had the information displayed as a standard part of the letter. The clinical director now reports more recent audit has shown an improved rate of recording diagnosis in memory clinic letters. There is often confusion about the terminology around early diagnosis. There is no evidence that making a diagnosis of dementia prior to clinical presentation is advantageous, but there is widespread consensus that we should make a timely diagnosis through a memory assessment service so that patients and their families can plan ahead, avoid inappropriate hospital admissions, and prevent nursing home admission for as long as possible. Inevitably, there are conflicting issues in diagnosing dementia, and every consideration needs to be given to the needs and wishes of patients and their carers. just as we do not embark on disclosing a terminal cancer diagnosis without first exploring patients' thoughts and issues, so we need to tailor the timing and presentation of diagnosis appropriately. However, the window of opportunity for patients and their families to plan while the patient still has capacity can be small, so here are the issues in the early stages of dementia. Firstly, we need clarity about diagnosis. Secondly, helping patients and families plan in advance for loss of capacity by enabling patients to make decisions about hospital care, life-prolonging treatment and financial arrangements while they still have capacity. Thirdly, maximising patient function by treating any existing disorders and prolonging independence. And finally, providing information about advisory and support. Clarity around diagnosis means being certain the diagnosis is dementia. While we have discussed the disadvantages of delaying a diagnosis, we also need to avoid the pitfall of a false diagnosis. If, after full assessment, the diagnostic criteria for dementia are not met, the diagnosis should not be made. Dementia is a clinical syndrome characterized by widespread impairment of cognitive function. Although many people with dementia retain positive personality traits and personal attributes, as their condition progresses, they can experience some or all of the following: memory loss, language impairment, disorientation, changes in personality, difficulties with activities of daily living, self-neglect, poor insight, psychiatric symptoms such as apathy, anxiety and depression, and out-of-character behaviour. The new Dementia Direct Enhanced Service is in the process of being introduced nationally. This slide and the next outline the actions required. The key actions that have to be coded in at-risk groups have been built into the Dementia Diagnostic Pathway recording template that has been developed, and practices can use these prompts as they see fit. The prevalence rates for the different types of dementia demonstrate that the vast majority will have Alzheimer's disease and/or vascular dementia. The differentiation between different types of dementia is based on clinical features. Although brain imaging can denote the characteristic pathological features of each type, it is not generally essential to make the diagnosis. The South West Oxfordshire Locality Memory Assessment Service is only designed to cover patients presenting with likely Alzheimer's disease and/or vascular dementia. Those with features of Lewy body dementia would be more suitable referral to the specialist memory clinic. Here is an outline of the South West Oxfordshire Locality Primary Care Memory Assessment Service. It is based on the GP assessment of cognition, a 3-stage assessment process to evaluate memory problems, exclude other conditions and/or identify problems that might be impacting on memory or function, and record relevant data on a computer template. There are many types of cognitive assessment. The traditional and gold standard mini mental state examination is still the usual formal test, but it takes about 8 minutes and is under copyright. However, the GP assessment of cognition, known as the GP Cog, takes only a few minutes and is widely available. The 6-item cognitive impairment test is of limited use because of a complex scoring system, and the abbreviated mental test used in hospitals is not recommended for diagnostic purposes. So why are we recommending using the GP Cog? Well, it is simple to use, well validated, and with comparative accuracy to the MMSE. It is more independent of level of education than MMSE, and it is widely available, including in other languages. The GP Cog is good at ruling out dementia. On its own, it cannot rule in dementia reliably at mildly abnormal scores, any more than any other cognitive test. However, at lower scores, it is more likely to be ruling in dementia. For those of you who have not used the GP cog before, here's a quick run-through of the test. The patient questionnaire consists of first giving the patient a simple name and address to memorise. The next question is to test orientation by asking for the date, including month and year. Then, visuospatial function is tested by carrying out the clock drawing test. The patient is asked to mark the numbers on a blank drawn or printed circle to show the numbers of a clock face, and then mark in a specified time using the hands of the clock. The patient is then asked to recall a specific item from the recent news. And finally, the patient is asked to recall the name and address that was given at the start of the test. This is how the GP cog patient questionnaire is scored. The result is out of 9. This shows the interpretation of the GP cog patient questionnaire score. A score of 9 shows no significant cognitive impairment and no further action is required. A score of 5 to 8 shows the need for more information and an informant questionnaire should be arranged. A score of 0 to 4 suggests significant cognitive impairment and a further assessment for dementia should be arranged. The informant questionnaire should be completed by an informant who has known the person for some years and who has almost close or daily contact. It has 6 questions that assess how the person is compared to 5 to 6 years ago. The informant will generally be a family member and who may have accompanied the patient. The questionnaire can be carried out by either asking the informant to complete the paper questionnaire or by interview. If the informant's score is less than 4 out of 6, cognitive impairment is suggested. As you can see, the informant questionnaire includes aspects of both memory and executive functioning. What about all the other special tests that may be done? There are many different types of tests that assess memory and executive function, including a potential battery of neuropsychological tests. Listed here are some of the ones we commonly see reported in letters from the specialist memory clinics. All are validated in dementia to assess memory and/or executive function, but none has any greater diagnostic accuracy overall than the tests that we can do. Whatever cognitive assessment scoring method is used, the diagnosis of dementia cannot be made safely without evidence of functional impairment. Executive dysfunction contributes significantly to functional difficulties as well as memory loss, and in this context reflects global functional impairment related to higher cognitive processes, although psychologists may have more specific definitions. Activities of daily living vary in complexity and difficulty and are typically divided into basic and instrumental. Basic ADLs, such as bathing, toileting, feeding and dressing, tend to be preserved in early stage Alzheimer's disease with links to motor rather than cognitive difficulties. In contrast, instrumental ADLs, such as handling finances, shopping, using the telephone and managing medication, are vulnerable to the effects of early Alzheimer's disease, with evidence for a direct link with cognitive status. There are just as many tests to measure functional impairment as there are to measure cognitive impairment. None is proven better than another, and all have their limitations. The Bristol Activities of Daily Living scale is probably the most straightforward and accessible. It can be scored from 0 which is normal, to 60, fully dependent, but there is no consensus or evidence to correlate score with the degree of functional. Therefore, for the purposes of the Primary Care Memory Assessment Service, the results of the Bardell's questionnaire, which can be completed by an informant at home, can be used to summarise the level of functional impairment without formally scoring the responses. The GP-COG IQ also assesses executive function. Using the information gathered, including at interview, an overall assessment should be made of both activities of everyday life and personal care, based on the level of impairment in these two fields. We now come to the South West Oxfordshire Locality Diagnostic Pathway, which is designed to identify and assess those with a cognitive impairment. At the first stage of presentation, initial screening may indicate no evidence of cognitive impairment, and these patients do not need further memory assessment. Those who go through the 3 primary care assessment stages would be expected to be diagnosed with either mild memory disturbance, which is the most approximate term and code for mild cognitive impairment, or dementia, and which type would be according to clinical picture. If there is still a diagnostic difficulty at the end of the 3 assessment stage process, then onward referral to a specialist memory clinic service would be appropriate. Whether a patient presents directly with a memory concern or is identified through a dementia DES inquiry, this initial assessment should cover the checklist here and record these on the Dementia Diagnostic Pathway template. If the GP-COG score is 9, the patient doesn't need further assessment and can be reassured. If the GP-COG score indicates some cognitive deficit, the patient/carer should be asked to make a 20-minute appointment with a practice nurse for further tests and supplied with relevant forms to complete at home to bring to the second assessment. The relevant forms are the GP-COG IQ, unless done at this initial assessment, the PHQ-9 and the Bristol Activities of Daily Living scale. The patient or carer should be asked to make a third appointment with the GP, also for 20 minutes, 1 week after the second appointment, to review the results and discuss what they mean. Here is a summary of the interpretation of GP-COG scores. Those patients with an initial GP-COG score, patient score, of 4 or less are likely to have dementia. Those patients with a GP-COG patient score of 5 to 8 and an informant questionnaire score of 0 to 3 are also likely to have dementia. Those with a GP-COG patient score of 5 to 8 and an informant score of 4 to 6 may only have mild cognitive impairment. Confirmation of these initial indications is required through the next stages of the assessment process, including an estimation of functional impairment. The components of the Dementia Direct Enhanced Service that are relevant in the initial assessment are shown in red or orange and incorporated here for pragmatic reasons to assist practices, but are not part of the Primary Care Memory Assessment Service. The codes in orange have been adopted pending the release of new codes expected in the autumn, and practices can then arrange for the codes to be adjusted. The details of the first assessment should be coded on the recording template as set out here. In order to comply with the expectations of the National Dementia DES, the code for referral for further memory assessment should be used, and then an additional code selected for the service chosen. We have adopted the code Referral to GP Assessment Unit to represent those who are suitable for the Primary Care Memory Assessment Service. Not all patients are going to be suitable for the Primary Care Memory Assessment Service, and this slide lists those in whom specialist referral is indicated. However, anyone outside this list in whom there is initial indication from the first GP-COG that there is some cognitive impairment can be managed in the primary care service. The patient-carer should be asked to book a 20-minute practice nurse appointment for stage 2 of the assessment pathway and a 20-minute GP appointment a week or so later for stage 3. The second assessment would normally be a 20-minute appointment with a practice nurse to cover the items listed here. Note that the PHQ-9 and the BADLS could be done at home by supplying forms in advance of this appointment. The detail of the second assessment should be coded on the recording template as set out here and on the next slide. We know it is often helpful to record who is the primary carer of someone who has cognitive impairment, and their contact details can also be useful. So although the code is required for the Dementia DES and is a new QoF indicator, it is also a key component of the primary care memory assessment service. The third and final assessment should cover the issues listed here, at the end of which a diagnosis should generally be reached. We discuss the use of CT scans on the next slide. The rationale for a CT scan is to exclude other pathology that could be responsible for a patient's declining cognitive function, such as space-occupying lesions due to malignancy or chronic subdural hematoma. It is not to differentiate types of dementia, although the scan may report corroborating features such as cerebral atrophy. As part of the Primary Care Memory Assessment Service in South West Oxfordshire, GPs now have direct access to CT scan of the brain through ICE using the limited access route. The guidelines listed here to indicate when a CT scan could be requested have been drawn up in consultation with the clinical director of the Memory Clinic Services in Oxfordshire. The detail of the third assessment should be coded on the recording template as set out here. The codes for Seen in Memory Clinic and Dementia Care Plans are to help comply with the changes being implemented to the Quality Outcomes Framework. A dementia care plan would include explaining the diagnosis and supplying written patient information about this, making a referral to a dementia advisor or giving contact details to the carer and arranging a dementia review. It is good practice to supply a copy of this consultation record to the patient and the person with them, as this would serve as a summary of the information and recommendations made as part of the care plan. If acetylcholinesterase inhibitors might be appropriate, supply the patient or carer with the appropriate advice leaflet about the drugs being considered and arrange a follow-up appointment so that they might be treated if chosen. We discuss indications for possible onward referral on the next slide. At present, there is no direct access to community psychiatric or memory nurses, but this may become an option in the future. It is possible that even after the 3-stage assessment process, and even if a diagnosis is made, there may be times when an onward specialist referral may be required. Here are listed some of the possible reasons. If, on the basis of the GP assessment of cognition scores and functional impairment, there is not sufficient evidence to make a diagnosis of dementia, the diagnosis should be one of mild cognitive impairment. This requires coding as mild memory disturbance because there is not a suitable code for mild cognitive impairment. No evidence exists that acetylcholinesterase inhibitors are of any benefit in mild cognitive impairment. There is some evidence that cognitive stimulation is beneficial. A review should be arranged for repeat testing in 6 to 12 months, as those who are progressing to dementia will become evident in time. In the meantime, encourage a healthy lifestyle and address any vascular risk factors. The diagnosis of dementia should only be made once all the relevant information has been collected and reviewed. The diagnosis should be given by ensuring that a family member or carer is present and using the principle of breaking bad news. Explain that tests seem to show that the patient does have a problem with their memory, which is affecting how they manage day-to-day activities. Ask the patient if they are aware what the diagnosis might be, and would they like you to explain what you think the diagnosis is. If so, use the term dementia and explain this is likely to get worse in time, but probably only slowly. Always supply some written patient information, such as the leaflet at patient.co.uk. The initial management of dementia should cover the following issues. It may be difficult to cover them all straight away, but they should be covered at some point. Listed here are the actions for the patients and carer to consider. There is a clear distinction for drivers between a diagnosis of mild cognitive impairment versus a diagnosis of dementia. Many patients or their carers know when they are no longer safe to drive, and a patient with a new diagnosis of dementia must notify the DVLA. It is possible in very mild early dementia that a licence may be retained subject to annual review. Community dementia advisors in Oxfordshire are employed by the County Council. They provide advice by signposting the various support services available and providing much written information. ADS here. A patient with dementia can be referred to a dementia advisor by using a one-page referral form that a carer or relative could complete. The dementia advisor will then contact the carer directly. They provide information on understanding how to cope with the problems associated with dementia, finding out more about dementia training and support for carers, and finding out about local help and support, benefits and other financial matters. There are links here to videos about the role of the South Oxfordshire Dementia Advisors and the Abingdon Memory Cafe. As we are all aware, there is considerable controversy and debate about the usefulness of the drugs for dementia. The acetylcholinesterase inhibitors, donepezil, galantamine and rivastigmine can be used in mild and moderate Alzheimer's disease. The drugs are not indicated in vascular dementia, but can be used in mixed dementia if Alzheimer's is predominant. Memantine is not an acetylcholinesterase inhibitor, but can be considered if acetylcholinesterase inhibitors are not suitable or considered in severe dementia, although not recommended for initiation in primary care. NICE originally recommended acetylcholinesterase inhibitors for moderate Alzheimer's disease after a 2008 systematic review and meta-analysis demonstrated modest benefit for the drugs. This review showed that in 14 of the 22 trials, there was a mean benefit of 2.7 points on the 70-point ADAS-Cog score after 3 to 6 months treatment. The ADAS-Cog is the most popular cognitive testing instrument used in clinical trials. It consists of 11 tasks measuring the disturbances of memory, language, praxis, attention, and other cognitive abilities which are the core symptoms of Alzheimer's disease. Most studies reporting measures of function such as the Alzheimer's disease cooperative studies, activities of daily living also significantly favoured active treatment. The clinical meaningfulness of the reported small changes on clinical scales is the subject of considerable controversy, and one group suggests that a 4-point change over 6 months on the ADAS-Cog scale is clinically important. There is currently no evidence to support the use of one acetylcholinesterase inhibitor over another. A further systematic review of the evidence was published in a NICE appraisal in 2011, looking at the effectiveness of these drugs. Based on 17 new randomized controlled trials and 4 systematic reviews. The key points are summarized on this slide. The assessment group also had a number of concerns about the quality of the studies and therefore the robustness of the evidence. Nonetheless, the updated NICE guidance in 2011 extended the recommendation of acetylcholinesterase inhibitors to mild as well as moderate dementia. Although they were not impressed with the quality of the published evidence, they took into account the various arguments and submissions that are listed here on this slide. What about longer-term treatment with acetylcholinesterase inhibitors? It is difficult to draw firm conclusions about long-term treatment, as most drug trials average 6 months. The Domino study, however, reported that continuation of donepezil was associated with greater cognitive and functional benefit over 12 months compared with discontinuation. This represented about a 1.9 point increased score on the standardized MMSE. So, to summarize, we can use acetylcholinesterase inhibitors, but we need to be aware that the small but definite benefit in mild to moderate Alzheimer's disease compared with best supportive care for cognitive, functional and global outcomes is based on evidence from trials which is mixed, and there are limitations in the methods of assessing outcomes. As already mentioned, very few trials lasted more than 6 months, so it is only clinicians' reported views that suggest benefit may last for 2 to 3 years. However, there is an emerging view that some people with dementia respond to cholinesterase inhibitors much more than others, and it is worth at least a trial to see if someone is a responder. Side effects are common, especially gastrointestinal ones, and especially initially. We need to be prepared to discontinue the drugs when there is no longer any clinical benefit. This prescribing protocol is separate to this presentation, but is available to provide practical information and advice about how to prescribe and monitor cholinesterase inhibitors. Finally, the following slides summarize the stages of dementia. Not everyone will experience the same symptoms or progress at the same rate. These 7 stages have been taken from the Alzheimer's Association website. This 7-stage framework is based on a system developed by Barry Reisberg, MD, Clinical Director of the New York University School of Medicine's Silberstein Aging and Dementia Research Center. And finally, let us not forget that some senior moments are completely normal and not even confined to seniors.